I am delighted to announce the opening of the 2022 Health Big Data Future Forum. Good morning, good afternoon, good evening. I am Eun-young Lee, team lead of HIRA Big Data Department and your MC for the event. Today's meaningful event is all the more special with the participation of our valued partners from Denmark. I see there are also many online participants joining from afar Denmark. Let me take this opportunity to send my gratitude to all online and in-person guests who are with us today despite your busy schedule. Today's forum will start by introducing our valued guest and will be followed by opening and welcome remarks, in-depth presentations, and Q&A session before closing. So I would like to make an announcement to the in-person attendees. You would be able to see the receiver on the table. So for channel 1, you would be able to listen to Korean, and for channel 2, you would be able to listen to English. I'm delighted to introduce our guest of honor. Thank you very much for blessing this event with your presence. Mr. Einar Jensen, Danish ambassador to Korea. Let's welcome him with a big round of applause. Next is Sunmin Kim, executive director of HIRA. Mr. Randy Monk, medical counselor, Danish embassy to Korea. Mr. Lars Seidelin Knudsen, team manager of the Shared Medicine Card Danish Health Data Authority, who is joining us via Zoom. Mr. Thomas Saxild, general practitioner, Denmark. Next is Mr. Youngjin Chang, team lead of My Data Task Force, Medical Information Policy Department, Ministry of Health and Welfare. Ms. Jin-sun Kong, team lead of International Cooperation Division, HIRA. Mr. Moo-sung Kim, head of Big Data Department, HIRA. Ms. Seung-mi Yu, team lead of International Cooperation Division, HIRA, is also with us today. Thank you all for blessing this event with your presence. Let me now invite HIRA's Executive Director, Sunmin Kim, to give us her words for the opening remarks.
Good afternoon. Hi, I am Kim Sun-min from HIRA. Distinguished guests, it is my great pleasure and honor to welcome you to this 2022 Health Big Data Future Forum held by the Embassy of Denmark and HIRA. On the way to this forum, I was reminded of all the collaborations we had with Denmark for the past years, which was a great joy for me. The Ministries of Health of Korea and Denmark signed an MOU in 2013 and continued collaborations. And also between HIRA and the Danish Medicine Agency signed an MOU with Korean President and the Prime Minister of Denmark to work in the healthcare sector, to share and collaborate in the sector, and have been involved in many collaboration efforts. I wish to express my most sincere appreciation to the Danish government and embassy. We have some guests from the Royal Danish Embassy in Korea, and I'd like to thank the embassy and Mr. Einar Jensen. On this Children's Day, the Embassy of Denmark paid a visit to general hospitals to bring octodolls and Lego bricks to children with cancer with messages of hope and encouragement. The embassy is also leading the efforts to digitize healthcare systems in hospitals and promote exchanges between smart hospitals in Korea and Denmark. The embassy has contributed to solutions for common challenges in both sides, for example, by holding the Korea-Denmark primary healthcare and infertility treatment seminars, which was challenges shared by the two societies. And also, in response to the presentations of Danish representatives, I'd like to thank Jang Hyung-jin of Medical Information Policy Department from the Ministry of Health and Welfare, who will introduce Korean government's direction for Health My Data. In my visit to Denmark in November last year, at the time, I could learn a lot about Health My Data in Denmark, and Mr. Lars Seidlin Knudsen will introduce their system, and I'm really happy to introduce him. And at the time when I visited their primary care facilities, we were welcomed by the representatives, and they spent a lot of time greeting us. And I would like to thank Mr. Thomas Sachtlin for his presentation today. Today's world is observing the emergence of the fourth industrial revolution based on data, network, and AI. The COVID-19 pandemic has accelerated the adoption of data economy and the transformation. My data is receiving much attention as the new source of added value, as it enables transfer and utilization of data when the information owner wishes to. I think Denmark is the leader in the world in this area. And in line with such trend, HERA's DUR service launched an effort to simplify the search process for personal history of medicine consumption history from last month. The intention is the same, and we want to simplify the services for our users so they can search their history. Previously, we did not have a system for doctors to check treatment history of the patient from other health service providers. To improve accuracy and safety for emergency patients, HERA initiated Emergency Treatment Support Data Pilot in September 2021 to share patients' treatment history and support doctors to make decisions faster in 4 general hospitals in Gangwon Province. We're going to put more efforts for this direction and collaborate with the Danish government. When I visited Denmark last year and on the way back to Korea, I learned a lot of knowledge and I got lots of Lego blocks from the airport. The Lego bricks, when I was looking at the toy, the power of Denmark was felt in the Lego bricks because I could see how delicate they were. And the digitalization of health record from Denmark that I only had seen in papers, I could really learn from watching them, and I'll do my best to reflect it in Korea. And I installed 4 apps from Denmark to be reminded, and I show that to our employees that this will be our future direction. Today, this forum will be one occasion for that direction going forward. Once again, I'd like to thank Ambassador Anna Jansen. Thank you very much.
Thank you very much for your words of welcome. Now, Mr. Ambassador Einar Jensen will deliver his welcome remarks.
First of all, I would like to thank Executive Director Ms. Kim from HERA for your kind words and your warm welcome. I'm not sure we deserve all these kind words, but it is true we went and saw a number of kids in hospitals around Children's Day, and it was a real pleasure for me to go out and spread a little bit of enjoyment for those kids who have a difficult time. So we really like that. And I remember Copenhagen last year also. We had the opportunity to meet just very briefly in the ministry, because one of the head of departments had fallen ill, and they asked me to come and meet you, which was a great pleasure. So thank you for hosting this important event today on big data and digitalization. I'm very happy to share the Danish experience with health data and a very unique journey Denmark has taken within digitalization over the years. Denmark has prioritized digitalization for more than 20 years now. And today the Danish healthcare system is among the most digitalized in the world. Of course, you can say we're only 5.5 million people, so it might be easier than Korea with more than 50 million people. Data and digitalization are important building blocks for shaping the healthcare system and the future. The foundation of the Danish healthcare data was created more than 50 years ago with the integration of a unique ID number issued at birth to all inhabitants of Denmark. So ideally you can follow every person from their born till they, die again. A solid digital infrastructure in the healthcare system and high digital literacy among healthcare providers has been instrumental in their success. In combination with a unique Danish culture, where trust in others and trust in the health authorities are important factors when it comes to sharing data. At the same time, Denmark has a long-standing tradition of digital monitoring and registration of patients in contact with the healthcare system. The Danish healthcare system is characterized by its digital communication between different health facilities as well as between health professionals. From general practitioners to specialists to hospitals, the entire system is connected and can communicate with each other. And that's quite a strong point that is not seen in many countries, you could say. Even though health professionals use different IT systems, they all use the same language and the same data format. All this is, of course, in order to create an efficient healthcare system and ensure the best healthcare service for patients. During the COVID pandemic, Denmark's solid IT infrastructure and our health registers enabled the health sector to respond to COVID very rapidly. Without digitalization, Denmark would not have been able to establish an efficient monitoring system of COVID cases and PCR tests within months of the outbreak. The digitalization and infrastructure made it possible to test, sequence, and publish data on a day-to-day basis for the entire country through the last 2 years. And the data collected made it possible for Denmark to assess the situation and lift all COVID restrictions back in February this year. So in Denmark, no more precautions are taken. Nobody wears masks anywhere. Quite different from what we see in many other places. In Denmark or in Korea, you have the same ambitions of digitalization as we do in Denmark. And furthermore, you have a great starting point with a high level of professional care at your hospitals and highly advanced systems that you can be very proud of. I look forward to the knowledge sharing between Korea and Denmark today, and I'm sure that we can achieve more together. Whenever we have innovative ideas and we learn, we take one step higher, and that's a benefit of two advanced countries working together. I hope this will be the first of many occasions to share knowledge and digitalization on healthcare. So I wish you all a very fruitful seminar today, and thank you for inviting us. 감사합니다.
Thank you for the remarks. We're going to have a group photo time. Now we will move on to the presentations. Our first speaker is Mr. Thomas Saxild, who will give us a brief demonstration of the digital patient administration in general practice in Denmark. Mr. Saxild graduated from Copenhagen Medical School and is currently serving as the head of Læge Praxis Clinic. Mr. Saxild is joining us virtually from Denmark. We have set aside 20 minutes for the presentation. Please welcome him with a big round of applause.
Okay, now it's okay. Sorry about that. Denmark, we are the gatekeepers. So I'll give you a little demonstration of that, and after that I'll give you some demonstration with our clinic system and both our medicine or for communication with other health providers, and I'll give you a small introduction to the apps. I think the director demonstrates before. So just to remind you that the family doctor in Denmark is gatekeeper of the health system. 8 out of 8 patients in Denmark, of the 5 or 6 million people, see their doctors every year, and only about 5% end up with an admission to a hospital or specialist. So we really very special here in Denmark. It's a good system. So if we send 1% more to the hospital will be overwhelmed by 10% more work. So, as already the ambassador told you, all communication now is electronic. We have templates for everything, for admission or to talk to the commune or other health providers, and all the information goes fluid between the sectors, both from the hospital to the doctors, and we can also, without sending people, we can correspond like chat with the specialist about one patient, question about patients. Also from the municipality, the commune can talk to us. So we are actually online more or less 24 hours a day. As the ambassador told, there are different systems in Denmark. We have about 7 different family doctor systems, but they all use the same platform or the same, we call it a platform for interchange. It's a special system was built for about 20 years ago called Medcom, and so that's secure that the all seen even if it's there are different systems, it will all be the same, that the outcome at the receivers. So that's a very good system we've made. And here you see all the standards communication. You can click on it if you get the presentation, and then all in Danish, so you can't read it, but there is referral for the hospital, X-ray, for the specialist, platform for physiotherapy, for psychologists, for the municipality referral, and emergency municipality referral also. And so we have a standard with all information that go fluidly, like patient's CPR number, contact information of the patient and the family doctors, so we don't have to write that all the time. So when we start with admission, we always have this like a scabulon with where we put on why we admit them, the history of the actual problem, and relevant medication, lab, whatever. So but we also have some we call dynamic admission with phrases for special diseases like cancer, X-ray, and the municipality admission. So now, no, I really get stressed because now I'm going to stop sharing this one and start sharing another one. And it could be very anxiety provoking to start sharing here. And this is my system now I'll share with you. So I see here, this is not a real patient, a dummy patient. We call it, it's a test person, so nobody get hurt when I demonstrate this. This is my front page. It's on the left upside, you see all the patient's name and CPR number and all the information. And then I open my system here. This is my working system where I can write anything here. And you can see this is a note I have here. I can put diagnose on here. You can see she suffered from a lot of the severe diseases, this test person. But if I like to make a referral to the hospital, I can show you like this. And here comes all all the thing I have to, like specialists, X-ray for the hospital, psychologist, physiotherapist, and food therapy, chiropractor, dynamic. And now it's just show you one of the hospital. So here I can choose the hospital, and I live in Copenhagen, so I choose Bispebjerg. That's my hospital. And here comes the foreman, and you can see this is my history of this, and this is what I found is objective. Here you see the lab. If anything relevant, I can get it from here, and I can put it from lab and back again. And here medication, so I can check this in, and comorbidity, allergy, or practical things. And then this is okay. And then I share this and then say, would you like to put a diagnosis in? And I say something. Yes, and I put a diagnosis in here. And then what I like to have a test in her. And then here you see the hospital, and it's a normal elective admission, and it's ambulance. So this is no hush. So this is, and actually here I can put on, if you have some documents like this, and EKG, I can put this on, or whatever in here. So then this is what I put on, and then I can send it, and it's go like this. So just to show you, the next one was the special what we call dynamic with the phrases on. Like I said, this patient have cancer, I think in like health cancer for breast cancer. So put this, and then it says all together. Now this is the hospital that you have to be. So the referral goes directly to the department, and I open this one here. And now see there's some phrases here. Also my text here, but here are the phrases I have to put on. If like there's any biopsy, metastasis, what I found, whatever. But this is Danish or maybe Latin, but I don't think you can understand it. But this has to be filled out, and then I can down here I can say what have you told the patient. Did I told you if there was a cancer package, and if it is, then I have to say yes, I have done that. So, and when I do that, they will actually have in 14 days it will be at the hospital. So I now stop this. Let's see, Annelia. I don't want to send this one here. Okay, and then I stop sharing this one here again. And see if we can find it out here. This. and stop share and share the screen again. Boom. Do you have my demonstration, my presentation again? Yes. Okay. Then we also have a common platform for medicine. That also demonstrate after that, of course, increase the patient safety. So every health providers can see the same system for medicine. So nobody, there will be no blind spots anymore for what the patients are taking. Also, vitamins or whatever will be on this system here. So we also have some. I'll show it later. 2 seconds. We have some help in the system to minimize the risk for interaction or when you prescribe medication. And now, I promise you the last time I switched again here, and boom. Let's see, let's stop sharing again here, and then try this again here. Share screen. Okay, there. So I'll demonstrate our medication here. So this is how it looks. It maybe looks very confusing, but you see this the medication. Let's say I would like to give this patient some medication for some medicine for easy telephone. New one. No, new set. I would like to make a recept for easy telephone. Whatever. That's in April, So when I do this, then I say this is for the blood pressure and fine, and then okay, what did I do here? Try again. Boom, that's it. So doesn't work really good for me today. Sorry. Try again here. But this should be very easy. And maybe it is because it's an old patient here. I can do something else. I can take another patient here. Maybe it's because like this. So if I make a new, like here, new ordination, so say here, and it's just like, I just start to write here. I thought because it's a dummy patient, it didn't work before. So I would like to put something for my hemorrhoids on here. They said boom, from here, and then there's actually up here. There's some what's a cave. If anything wrong, they could put it up here. So now I can go to the hospital, to the pharmacy, and pick up my medication. So, and you can see here, you can see when I prescribed it, and the medication, the strength of the medication, the tablets using, the dose, if you have an indication, or this is the HSC name, and this is the last time I pick up my medication, and here you can see also if I do this, and I can ask my doctor to send a new one, because I can actually put a mail to my doctor, and then I can send it a new one for us. And here I can see when the medication has been delivered and when I started. So this was a very brief, but very this is very good and safe system we have here. So now I go back to my presentation, and only one slide left. So see here. Stop share. And boom. So this was a very, and hopefully not too confusing for you. Maybe this is the apps we have here in Denmark to contact our doctors. It's called My Doctor. Also, you can have my medical cards, my medicine. Also a good card, or in the region of capital region of Denmark, we have my SP, the hospital app, that gives patients unlimited contact with the family doctors, and you can remove medicine, see lab results, make appointments, make video consultation with the doctors. Also, we have on the internet called Sundhed.dk. That's where you log in with your CPR number, like only you can see your information about your health, information from hospital appointments, result of all examinations, vaccination also, donation if you have made that too. And then here you see a sample of which one up here is My Doctor, Min Læge. It's a green one actually, but this is the patient use, and just call up the doctors instead of going to the doctor. They can make an appointment on video. And my SP is the communication with the hospital, and this is Sundhed.dk. You can see here. So it's whatever happened to you, vaccination, medicine cards, the journal from the hospital, X-rays, and there's a Corona pass also, and COVID answers. So actually, it was my maybe brief and very confusing to go through my system. Sorry about the problem we had on the way. So that's the end of my presentation here.
Thank you very much for your insightful and informative presentation. Now, the next speaker is Mr. Lars Seidelin Knudsen, who is a team manager of the Shared Medicine Card Danish Health Data Authority, who has graduated from Copenhagen Business University and is the incumbent team manager of the Shared Medicine Card Danish Health Data Authority, who is also joining us from Denmark and will be talking about the Shared Medical Record System of Denmark for 10 minutes. Let's welcome him with a big round of applause.
Thank you very much. It's a pleasure to be able to attend today. Thank you to the Executive Director and Hira, and thank you for the VIPs and the ambassador to be joining. I'd like to speak today about the shared medication record, and I'll be sharing a presentation here. And I believe that you can see my presentation now. What I'll be talking about is a bit about the purpose for the shared medication record, the implementation, the results, and the future of the medication record. The shared medication record was built to be one centralized system with information about the current medication for all citizens in Denmark. And it was made in order to ensure the high quality and the patient safety and improved treatment for Danish citizens. It is this system which is working so as the shared medication record, which is in the center, the doctor can prescribe medication. As Mr. Thomas Axel showed you, the medication from his system, from the doctor, he could prescribe, make prescriptions, he could view the current medication of the patient. So that is what the doctor in hospitals and general practitioners could do. The pharmacy can also see the medication of the patient and hand over prescription medication. The home care, the commune, can administer medication and is also viewing the shared medication records in order to do this. And the citizen can view their current medicine and they can order prescription renewal of their medication. So it is a central system which all doctors, all pharmacies, all home care, and all citizens use. It's by legislation that they should use this. They cannot use another system, and it's real-time synchronized. That means when the doctor makes the prescription, as Mr. Thomas Axel did, it is already shown to the pharmacy which kind of medicine they should hand over to the citizen. So this is in the former days before the shared medication record. The emergency department, they could be in this situation that the patient would come, be unconscious, and the parents of the patient could come with the medication or and show which medication they might have been taken, what was in their medication cabinet. And it was not very easy for the doctor to know if they were actually prescribed this medication or if it was some other medication that they came with. And now with the shared medication record, they have the whole history of the medication of the patient. It was implemented first for general practitioners in 2014. The general practitioners helped to make the medication card for all citizens in Denmark up to date. So it was containing all the medication for the citizens. Then the municipalities and the citizens could see it. There was an app in 2016, and we are still implementation in different areas. The app looks like this. It is a very simple app where the citizen can see the current medication, they can see the prescriptions, and they can order a prescription renewal, which then the doctor will receive in their system, and they can approve that the citizen can go to the pharmacy and get the medication. Before the shared medication record, the doctor could only see a little bit portion of what the citizen might be taking of medication and other treatments. But when the light and the shared medication came on, the local doctors could have the whole medication overview and see the whole patient or the whole elephant. Some of the results of the shared medication record. This is a graph showing the paper prescriptions in the red line, which is going downwards, and the green ones is electronic or digital prescriptions, which is going upwards. So about 98% of all prescriptions in Denmark is now digitalized and can be shared throughout the health care system in Denmark. Some of the changes for healthcare professionals, which was provided with the shared medication record. It is a system which is embedded locally in systems, supporting the workflow of that particular system. So when Mr. Thomas Saxel shows the medication system, it is localized for his system and his use, and it will look a little bit different for the pharmacist who needs other information, but it is all centralized and it'll all be communicated to a central system. It is online and real-time updated, and it has access to all medication information for all citizens in Denmark. It has been a challenge to initially update all the medication and be sure to have updated and correct use of the shared medication record. It's a new system. People needed to learn it in the beginning to get to know it, but it's been used now for almost all parts of the 98% of the prescription. Some positive changes for the citizens. They have access to their own prescriptions and their own medication that gives patient empowerment. They can communicate with the doctors what kind of medication they're taking, and they can see themselves what the doctor has prescribed for them. It has thereby increased the patient safety as well. Some of the challenges has been with privacy and access to data. Some people have been concerned about what to share and not to share. In Denmark, we have great trust in Denmark towards the government and towards the healthcare system. So we have chosen in Denmark that we can share this information across sectors in the healthcare. Some changes for the society. We have now one medication system which has been proven to work and have given patient empowerment. It has reduced the use of medication because the doctors can now see what there already has been prescribed other places and can prescribe the right medication, which also leads to better patient safety. It has been a large program and has been challenging to change the mindset of people in the healthcare industry, but they have all been very supportive and been sure to be stakeholders and back up the use of the shared medication record. Some of the futures for this shared medication record is that we're looking into artificial intelligence and augmented reality, and we are making some alterations to the prescription, how prescriptions are made. Because we have all been digitalized, it's easier to make these alterations. This was the end of my presentation. Thank you very much for your attention.
Thank you, Mr. Knudsen. The next speaker is Ms. Randy Monk, healthcare counselor at the Danish Embassy to Korea. She studied law at University of Aalborg and became an attorney. And Counselor Monk has worked for a Danish pharmaceutical company in patents and regulation for 15 years. She's an expert in law who served in the Danish Medicine Agency in permission acquisition for medicine and medical device. She's here with us on site and will introduce personal health records and the legal basis in Denmark for the following 15 minutes. Please welcome Counselor Monk.
Thank you very much for inviting me to this very interesting seminar today, and thank you for your interest in Denmark and the Danish healthcare digitalization. My name is Randy Monk, and I'm the Health and Life Science Counselor at the Danish Embassy. I have a background as a Danish lawyer and have worked extensively with health data in both the private and the public sector in the European Union. And so I'm very happy to be invited to this seminar, as normally the legal people are not so popular with the data people, as we often act as a bottleneck in these procedures. So very happy to get the invitation. Today I'll be sharing some of the main structures in the Danish legislation that enable us to use and share patient health data between the public entities in Denmark. So how do I shift slides? So, as we've heard from the previous speakers, digitalization in Denmark is not something that happened overnight. It's been ongoing for more than 20 years, and we are still refining the technology and adjusting to the new digital landscape and the need of the patients. In Denmark, we have a very long-standing tradition of collecting data and making registries. Systematic and digital collection of data enable us to do these large-scale monitoring, as we have done with the COVID, and do analysis of health data, as well as the patients in contact with the healthcare system. And Denmark is probably one of the countries in the world with the most registries per capita. Alone in the health registries, we have more than 160 different registries with data varying from different types of cancer, birth, cause of death, and many more types of registries. These registries is also what enables the Danish scientists to do this first-class research in all varieties of disease areas for the benefits of the patients. From a legal point of view, the legislation is always going to be a bit behind the technology. We cannot develop the legislation fast enough as the technology is being developed, so it's very important to find a balance between privacy measures for the patients and also the need for pragmatism in the healthcare sector. So this is just a brief illustration of the Danish healthcare system. As you can see, Denmark consists of 3 pillars. We have the state level, the region, and the municipalities. The state is responsible for the more legislative system, and new legislation must of course be passed in the parliament. This is also just a brief overview of the Danish healthcare system. As you can see, it's based on taxes from the citizens, which are distributed via state level to regions and municipalities. So citizens do not have that much out-of-pocket payment within the Danish healthcare system. And it's also another way of displaying the level of trust in the Danish society. You do not pay your local GP or doctors at the hospital directly, but the patients has trust in the service and advice given because it's such an integrated way of the Danish way to do it and the way patients view their data. As the former speakers also noted at, the flow of patient data in the Danish healthcare system is quite important because data is coming in from everywhere. In Denmark, we have a free choice of doctors and specialists, so data could come from multiple GPs, specialist hospitals when calling 911. All data are collected and placed within the patient's health record identified by the patient's social security number. So no matter what health entity you visit, your data will be stored and within your social security number. As we heard earlier, the standards for integration between IT systems in the healthcare sector are prepared and maintained by a joint public non-profit IT provider called Medcom. Medcom is jointly owned by the state, the regions, and the municipality. So communication and data standards can be more streamlined when handled by the same company, which can be an advantage when handling these data. So onto the legal basis, we have access to data and we have lots of data, but one thing is what you have, but another thing is what you're actually allowed to do with these data. So for the legal basis of all this data flow in Denmark, it's important to note that in Denmark, we of course handle the patient's data with the utmost care and attention and in compliance with the legal framework. Overall, it's important to define what we mean when we say personal data. And the following definition is from the European General Data Protection Regulation, which also apply. The personal data is any information that relates to an identified or identifiable individual, as stated in the GDPR Article 4. So for the legal basis in Denmark, we have 3 main laws governing the patient landscape. Of course, the GDPR applies as Denmark is a part of the EU. GDPR overall states how general rules of handling personal information are handled, but the main legislation is found in the Danish law of personal data and the Danish health law. In these 2 legislations, specific issues and situations regarding sharing of personal data is stipulated. Besides the 3 legislations mentioned on this slide, there are also other laws quite relevant for patient health records and handling patient data. It's the law of public government that governs the confidentiality obligations of publicly employed health professionals, which covers the majority of all Danish healthcare professionals. Also the law of authorization to the local GPs and hospital doctors. The law of authorization clearly states that a doctor has a legal obligation to record and collect data about a patient. which is quite an important obligation in terms of the patient's benefits of this. If a healthcare professional needs to transfer data to another healthcare professional, the overall legislation states that a consent from the patient is needed. But, of course, with a view to the administrative burden for the doctors, if data transfer is happening in accordance with normal procedure and the doctor has made an assessment about the need to transfer these data from the patient point of view, then you can, of course, make an exception. The legislation on this transfer of data applies both to electronically transferred data, but also paper, even though not a lot of Danish doctors actually use paper anymore. Electronic access to patient data is governed by the Danish health law, where it's stated that healthcare professionals can retrieve the relevant data for the procedure needed. This means that, for example, in an emergency situation, there's going to be a need to know a patient's recent intake of prescription medication. And if the patient is unconscious, like the example that Mr. Knudsen gave, the patient will, of course, not be able to give a consent. So in these cases, of course, the paramedics will be able to access all the relevant data because the patient's lives could depend on access to these data in order to make the right treatment. It could also be in a non-emergency situation. Example, if you're at the dentist and the dentist wants to give you some sort of sedation, it's also quite relevant for the dentist to know which prior medical data you have. So of course they can access on a limited basis your patient health record and only get access to the relevant data. So, as we can see, health data covers quite a broad area. Normally, as I mentioned, you would need a signed consent to use personal data in accordance with the personal data law. But due to the administrative burden, the law has covered this. So procedures happening in accordance with the authorities' normal working area can deal with the health data related to patients without seeking specific consent. This is, of course, very limited and only in the specific transaction that the authority is performing. It could be, for example, with side effects or adverse events, putting these into a registry. If the authority at some point would like to do some research into side effects, they will need to apply for access to data, same as every other scientist, in order not to breach the legislation. The law takes into account that GPs and other healthcare professionals handling sensitive and personal data needs to be able to perform their duty without too much administrative burden. For researchers, there's also some very valuable information in these registries and patient health records. And the Danish system, as showed earlier, enables the scientists to select and extract the relevant data for research very easily, as most of these data are compiled in the same place. So, with all this personal data, it's very important that the legislation is clear and the aim to protect the patients comes first. However, it's also a requirement that healthcare professionals can perform the duties without the administrative burden of collecting consent forms for all minor transactions. So this flexible system, of course, also means that we need some security measures in place, and government institutions, researchers, doctors, and hospitals needs to be extra attentive when handling patient-identified data. There's a lot of security measures built into these systems in order to make sure that the patient's privacy are not violated. Trust and compliance are some of the ground pillars in the Danish system, and the built-in mechanisms, such as logging all entries to the health records, is important to ensure this trust in the data. The National IT Service will also do random checks of the healthcare records, and of course the citizens are also able to see if anyone have accessed their files in order to assess if it's rightful or not. So, just to sum up the Danish data landscape and legislation, then Denmark has quite a unique system with registries going back more than 50 years. high quality data, and a continued focus on making a common European data standard across the European Union. And of course, we focus on a legislation that ensures the balance between personal data protection and the practical use of data for the benefit of the patients. Therefore, a focus on strengthening and accelerating the cohesive and collaboratory and digital healthcare system will continue in the future years, and I hope that we can work together with Korea on this project and share inspiration. Thank you for listening. 감사합니다.
네,
Thank you very much for your passionate presentation. So up to this point, we have been enlightened of the Denmark's shared medication record system, and now we would like to learn more about Korea, which leads me to the next presenter, Ms. Seung-mi Yoo, the team lead of International Cooperation Division, HIRA, who will talk about the digital transformation of universal health coverage in Korea for the next 10 minutes. Let's welcome her with a big round of applause.
excellent opportunity to share how Korea's digitalization of universal health coverage. My name is Seung-mi Yoo, and I'm a team lead from the International Cooperation Division of HIRA. So for today, I'll introduce the role and functions of HIRA first, and then I'll discuss how universal health coverage has been digitally transformed in Korea. So to talk about universal health coverage in Korea, it's essential to make reference to the national health insurance. So we started with a medical insurance for employees at large companies in 1977 and expanded to cover more people in a step-by-step process. So as a result, in only about 12 years, Korea achieved universal health coverage for the entire population in 1989. And the government carried another major reform in 2000 to develop a single and integrated payer system. So Korea's national health insurance system operates under three major acting bodies: the Ministry of Health and Welfare, the National Health Insurance Service, and the Health Insurance Review and Assessment Service, called HIRA. So the ministry oversees the overall NHI program, and NHIS is in charge of eligibility management and collecting insurance contributions. And the HIRA is responsible for setting the scope and standard of services that are covered by the NHI and evaluating the cost and quality of healthcare services. So Korea is one of few countries that can collect an all-inclusive data in healthcare at the national level within a centralized platform. This is possible because Korea mandates that all people and healthcare providers participate in its single-payer insurance system. So it's no matter who you are, what you do, and where you live, you are entitled to the same national health insurance program. So as you can see on the slide on the top, so NHI covers the entire population to provide all essential and medically necessary services. And second, the dominant health service provider is the private sector in Korea, but still, all providers, either public or private, should be part of the NHI scheme to provide services and submit claims to HIRA. So this is how and why we could maintain the private dominant healthcare systems even during the pandemic. And third, it's based on the single-payer system, so all residents and healthcare providers in Korea are under the same umbrella of the NHI system. And fourth, and lastly, HIRA has adopted ICT system from the beginning stage, and with the unique patient identifier and with the foundation of national health insurance, HIRA enables to collect, connect, and utilize health data across the country. So to be more specific, HERA serves three main functions. The first task, rulemaking, refers to deciding on what, whether, and when to cover, and how much to cover specific healthcare services like procedure, drug, and medical devices. And the second is monitoring the cost and quality of healthcare services, including claims review, quality assessment, and drug utilization review, and the trend monitoring for healthcare utilizations. And third, infrastructure management is performed to collect nationwide data on health resources and the claims, and to form a single national data warehouse, and then analyze this big data to then generate evidence. So the second part is how universal health coverage is digitally transformed in Korea. So whenever providers provide health services to patients, they submit a claim file to HERA through the web-based portal system. And then HERA conducts the claims review to check if the healthcare services provided on the claims are or like comply with the standard or rules. And this process is performed to prevent waste and verify the provided services are clinically valid. And then HERA sends the claims review results to NHIS within like 2 weeks. And then NHIS pays the providers according to the review results. And another main activity of HERA is quality assessment. It's performed to measure the status of quality of services and to improve the quality of care across the country. And we also operate the healthcare utilization monitoring system, or HUM, as a dashboard to monitor the utilization and expenditure as in cost side. And it displays the cumulative expenditure compared with the last 5 years and the annual forecasts. And this system predicts like any fluctuations in health expenditure and detect abnormal utilization pattern to provide info to make data-driven policy decisions. So the total like trend analysis of total expenditure in specific target items such as high-cost medicine or drug, high-cost medicine or like procedure are monthly performed to analyze the status and detect any like abnormal pattern. And then we operate real-time data exchange through like DUR, Drug Utilization Review System. It refers to the process designed to ensure that prescriptions are safe and not likely to result in adverse drug events. So DUR system was built to prevent and minimize unsafe drug use by screening medications in real time and comparing them to up-to-date standards within a prescription and between prescription in the past when prescribing and dispensing drug. So this flow in here illustrates the working process of DUR screening, which occurs in 2 ways, between HERA and physicians and HERA and pharmacists to double check the drug utilizations. And all the screening process is done in real time, and the screening responses are provided within 0.4 seconds of data exchange. So we have taken full advantage of the existing ICT network and data from patients and providers across the country to take a full-fledged action against COVID-19 pandemic. So we were able to take a rapid and flexible approach to deal with COVID-19 crisis according to what is needed during this emergency. So we contributed to preventing spread, detecting and treating cases early, and responding quickly to the surge capacity of the healthcare system. So we, with the real-time exchange feature of drug utilization review system, we were able to detect and track high-risk groups during the COVID-19 crisis and prevent the spread among healthcare facilities throughout whole stages of healthcare delivery, including at the reception, physician consultation, prescribing, and dispensing stage. The info provided as a pop-up alert include patients with recent overseas travel history, people who have close contact with positive cases, and COVID-19 patients who are just released from the quarantine. And next, we came up with stabilizing the national distribution of face masks in the crisis. So although face mask is not covered by the NHI scheme, HERA has taken full advantage of the pre-existing network system with nationwide pharmacists to ensure mask distribution to the public in the crisis. So following the government's decision to take complete control of face mask distribution in early 2020, HERA set up the national inventory or a supply system. This allowed providers to check the weekly purchase history of each person to prevent panic buying in overcrowded pharmacies. Then we also operate a health resource monitoring system to provide a daily snapshot of the resources that are used by critical patients, including isolation rooms, ECMO machines, and ventilators. This was possible because all healthcare providers in Korea should report their status of health resources, such as manpower, facilities, and equipment to HERA for claims and reimbursement purposes. So this system in crisis was able to identify hospitals with available resources and relocate patients in critical condition in a timely manner. So for the last slide, HERA collects data from various stakeholders such as hospitals, pharmacies, drug manufacturers, governments, and public agencies. As all healthcare providers in Korea submit claims to HERA, we were able to collect and process real-world data sets from the claims data and then build a COVID-19 global research collaboration platform and then share the COVID-19 patient database for research to generate evidence for novel disease. So thank you for your interest and attention, and just feel free to contact me anytime if you have require further information. Thank you.
Thank you, Ms. Yu. Now that we have been enlightened by Denmark's shared medication record system, I cannot but wonder the direction of Korea's PHR, which brings us to our fifth presentation delivered by Mr. Youngjin Chang, team lead of MyData of Medical Information Policy Department from the Ministry of Health and Welfare, under the topic of medical MyData implementation in Korea for 15 minutes. Good afternoon. Thank you for inviting me to this momentous event. My name is Chang Youngjin. I'm the team lead of MyData TF. I am going to introduce our Health MyData policy direction in Korea. First of all, as of now, the PHR, Personal Health Record, why the government is so much interested in the PHR. As mentioned by Ms. Kim, in this era, we are seeing the convergence between ICT and health data. in Korea, we have a high level of advanced IT and health data as well. And also our single insurer system for over 20 years with HERA and NHIS, we have massive amount of high quality health data. Therefore, for the convergence of IT and health data, Korea is in a very good position to go into this area. Therefore, using this environment, we want to use PHR with the convergence with IT, and we want to join this trend, which is very palpable on the globe. That's why our government is so much interested. And to utilize PHR, it's also connected to our environment because our demographic structure is changing, going to aging society, meaning that our demand for healthcare is increasing. And also due to the fourth industrialization and COVID-19, the awareness has changed. Now the remote health service and more diverse types of services are accepted by the public in a better way. Therefore, the types of services are changing in the international arena, and the industry is realizing that PHR can be utilized in a much better way. And at the center of this changing trend, there is this PHR. But then let's have a look at because our government has been interested in using PHR. Now let's look at the challenges. For the needs, we all sympathize, but how we do it and what is the future direction, maybe we have different opinions. Therefore, we are not speeding up in the utilization of PHR. If you look at the institutions, there are restrictions because our medical act limits the access and use of health data by non-healthcare providers, even when the patient agrees. And also, we need standardized data to be able to use PHR. And we don't know who can standardize the data, who can lead the effort, we don't know. And also, thirdly, in Korea, the privacy is the most difficult issue because we have privacy protection law in Korea, and the utilization of PHR needs some balance. And lastly, the owner of PHR is the public, so we need to have it clear what is the benefit for the public. The public needs to be able to learn the benefit when we utilize PHR, and that is slowing down the development in the policy. So for the solution by the government wants to advance this discussion, and in February, we discussed My Health Way pilot system. Under the given legal restrictions, the technical issues, which is the standardization of data, it should be able to provide it to the healthcare providers and the citizen systematically. So we need to build the infrastructure first. The public need to be able to see their own medical history at different providers, and they need to be able to utilize the data by themselves. So building infrastructure for that is what we are trying to start with. I used the analogy of car and highway. So PHR is the car, the owner of the car is the public, and the car maker is the providers. So what the government should do is to enable the cars to drive nationwide. So the government wants to build the highway, which is the infrastructure, given the legislative restrictions. The difference between the previous policy is that the central government is building the infrastructure, not the local government. And we have 20 billion Korean won of budget working with two government agencies which is KHIS and KHIDI. As I said, system is the infrastructure, and we also need the institutions. With the previous policy, it's hard to share PHR, and we have not built the new policy yet. We will open the system next year with the participation of 1,000 providers, but we don't have the standardization, what kind of incentive can be given to the providers, and who should participate. We don't have all these detailed measures and controls. So we need to change the systems. So the government Ministry of Health and Welfare is aiming to propose a law this August. So infrastructure and system change will drive the use of PHR. This is the framework of the system we're building currently. So the key is that under the given restriction, we will try not to save the data itself, but we want to be the relay system. So the public or the providers can use the data as they need after processing the data. We will be providing the highway and we'll try not to save the data. Let me move to the second agenda, our plan and current status. As I said, our government system is focusing on building a relay system. And we announced the plan last February, and we are working on building the system, and we plan to open it early next year. How to do it and how to open it for public is using the app, My Health Data app. We launched the app last February, and every month we have 50,000 users. And when the system is completed next year, with the participation of 1,000 providers, what the public can see in the system is the medicine history from HERA, treatment history from HERA, and also the KDCA record, those basic data. Because we have 1,000 providers across clinics to tertiary hospitals, the public will be able to see their treatment data across the level of institutions. Of course, the patient consent is a must. We do collect the consent. That is the way forward. And the national agenda by the President Yoon and his administration, we want to adopt baby health checkup, baby notes, recording system, and smart health system. We want to improve the convenience so that they can they can access their treatment data when they used healthcare service from clinic to higher level hospitals. We plan to expand this service. Secondly, not only limited to the medical services, but also when they claim for private insurance and when they need digital prescription. So we want to go the digitalization in the area of a wider health service. To be able to drive these policies, we need more budget and legislation. And as I said, we plan to propose the law in August, and we will apply for feasibility test so we can earn 600 billion Korean won of budget for the long-term projects. So the providers will voluntarily come in to participate, and we will be able to use the data for the right purpose without having to worry about privacy infringement. When it comes to legislation, yesterday there was a news where a financial company sold their privacy information of the users. So I believe that we need strong protection from the law. What we want to do, expected results are improved convenience by the public. I am raising a child, and when I apply for insurance, you need lots of documents from the hospital. We need to simplify those to enhance the convenience of the patient. And also the second agenda is the medical practice will change thanks to the innovation in the medical area. Maybe the fee schedule and also the medical treatments will be revitalized. And thirdly, not only the primary care, but also the within the community before you get sick, we can enjoy preventive measures from health center chosen by each individual, which will result in long-term reduction in expenditure in health. And lastly, we can also utilize big data and pseudonymized data, and we can use them for development of new drugs. So R&D can also utilize the data for deepened results. The biggest challenge is the scope of work that should be done by the government. When you look at the public area, we cannot share the data directly because of the legal restrictions. That's why we use the public app. But once the legislation changes, maybe we can change the current system. But the principle is that the government will be the relay agent. So without too much intervention, we will support the data exchange. The rest part you can read, and I'm going to conclude my presentation. Thank you.
Thank you very much for your insightful presentation. So HERA has been and is making significant steps to making my health data accessible and available to the public in line with the government's policy direction, which brings me to the last but not least presentation of the forum, an introduction to the soon-to-be launched HERA's Personal Health Record app delivered by Mr. Musong Kim, head of the Big Data Department, HERA. Thank you very much. Nice to meet you all. My name is Kim Musong from the Big Data Department of HERA. So let me start my presentation. So this is the contents of my presentation. So we are living in a My Data era, and I would like to talk about what the citizens are requesting from HERA, what we have in preparation, and how this would be able to benefit and make our citizens' life more convenient. So first, we listen to what the citizens have to say. As can be seen on the screen, the citizens are asking for safe and high-quality medical care and convenient and relevant information to everyday life. So they're wondering if someone is actually managing my treatment records and information and so on. I would like to know how much came out of my pocket, how much was been able to be covered by my health insurance. But this kind of information is so far away. So our citizens became very curious of this. So that's why HERA identified the main customers of HERA, which is the health providers, the pharmacies, and all the hospitals and clinics. So we had individual DBs for each of our health providers, pharmacies, and hospitals and clinics. But in order to service our customers, our citizens, with more information, we thought the need to have a patient-level database. And upon this realization, we started to push forward a patient-level database. So you will be able to see this app in the store this August. So we used to have a health information app, but we restructure it on a 2-year or 3-year basis. But in the process, we will be able to now provide my medical service to citizens. So in the past, it was called Health Information, but now the app's name will be renewed as 건강이음, which means connect with health. And you would be able to check detailed information on this newly launched app. So let's deep dive into the app. So in the past, you need to create an ID and input your password, but we tried to simplify and streamline this process as much as possible. So if you have an SNS ID or Naver Kakao Talk ID, you would be able to link it with the app. And as for sensitive data, we will be covering treatment data. That's why a secondary login method would be necessary. So this is the actual screen of the app. You would be able to see my treatment information menu. Click on it and you would be able to be presented with details. So the health insurance expenditure is more than 100 trillion won. And in some cases, for each hospital visit, you will pay 3,000 won or 5,000 won. But in some cases, you would wonder how much came out of your pocket and how much was covered by the insurance. So in this case, it says that the benefit is more than 80,000 won. And what came out of your, you paid approximately 80,000 Korean won. And you can see that the insured benefits is 50% and 50% came out of your pocket. So you would be able to know in detail of this information. And once you click on View My Treatment Information, you would be able to see your health insurance details and also the insured benefits for the vulnerable and also for veterans as well. So extensive information is provided. You would be able to see the treatment history of each hospital or clinic visit, and you would also be able to see the main cause of your visit, whether it was a headache or whether it was a stomach ache and so on. So this records would also be able to be accessed. And you can see the prescribed medications and dispensed medication details and list as well. So you can see the detailed information of your treatments, and you can click on the drop-down menu to also see the details of your auto insurance as well. And you can also see a lot of information at a glance. We put together not only health insurance information, but also added auto insurance as well, so that you would be able to check information all at once. So you can see how much you paid, how much was insured by your visit that you made to an internal medicine hospital, and so on. If you click on the prescription tab, you would be able to see the detailed prescription, contents, and history as well. And there's also something called My Health Handbook, which is kind of a personal assistance. You would be able to select medication, reminders, and so on. So there's a calendar that can send out medication reminders. In some cases, it could be vitamins or it could be prescribed medication as well. So you can set up an alarm to say, I need to take my stomach medicine after the meal or before the meal, at what time. I need to take my blood pressure medicine at what time. So all of this information could be managed by the calendar, which could send out notification reminders as well, just to make sure you don't forget to take your medicine. And you can also check a lot of detailed information in your health handbook as well. So this will also show the insured maximum or the covered maximum of your health insurance. In the case of dental scaling, you would be able to be insured once a year. So if you have used up that session, but 6 months later you want to pay a visit to your dentist again, since I have already used up my insured benefit, this time I will have to pay for all of the scaling session. And we also include information of the Chuna manual therapy to see how many sessions you have received and how many sessions are left that could be covered by your insurance. So there are many different devices that are all compatible with our services. So your personal health records would be able to be accessed via your personal computer, tablet, or smartphone. So it's device agnostic. We have prepared a flexible, responsive layout that would make you very satisfactory. So by doing so, we are aiming to empower our patients so that you would be able to check your medication or treatment history whenever, wherever you are. So by doing so, HERA is trying to ensure the citizens' right to know, data sovereignty, and increase convenience. So in the process of conducting public operations, data has been accumulated, but we are trying to give back that data or the right to use that data to our citizens. So as have been mentioned in the previous presentation, there is a highway, and on the highway, there are many interchanges and areas that are joined with different kind of roads. We work with NHIS, HERA, and also the Ministry of Health and Welfare. And in the process, data would be generated. By having a My Health Way, a bottom of My Health Way, all this data would be able to be gathered and managed in a consistent manner so that we can contribute to citizen convenience, make personal health data more accessible and available. So we have a HERA car, and KCDA has vaccination information and so on. So all of the public organizations are taking a role in contributing to empowering our citizens of their own personal health records. And by doing so, the citizens will be able to enjoy a more convenient way of controlling their own data. So this slide shows some menus and services that we are in preparation of. For instance, you can, this will require consent. This will require prior resent, but you can not only check your treatment history, you will be able to check your children's history upon consent. And for instance, if your parents are living from afar, you want to know if they are in good care, if they're receiving good medical care, and you are living afar. But with this app, upon consent of your parents, you would be able to check the treatment history of your elder parents as well, so that you can help your physically or mentally weak loved members. So next year, we would be able to offer additional services, but in order to do so, we will have to make sure that prior consent is given and the right legislations are in place. So this is the end of my presentation. Thank you very much for listening. And I would like to once again highlight that HERA is serving our roles and responsibilities, and we are in line with the government policies as well. Thank you very much for listening.
Thank you, Director Museong Kim. I hope you enjoyed the 6 insightful presentations and are ready to ask some questions. Before we dive in, we would spend 5 minutes to rearrange the seat before Q&A session. Thank you. I hope you enjoyed the 5-minute break. From 4 o'clock, we have listened to 6 presentations in a row, and now it's time to speak up and ask some questions. We also encourage the online participants to let us know if you have any questions in the comment section. If there is no question on YouTube, we will accept questions from the floor on site. Oh, we have a question. Hi, my name is Lee Gyuan. I am a researcher and I have a question for Counselor Randy Monk. The Denmark healthcare system was really advanced and stable. For example, the data template was standardized and you shared the data with the researchers in a smooth way. And in the new generation healthcare system, would you like to advise on the future healthcare system?
For the question. It is true that in Denmark we have access to these health registries actually through the Health Data Authority that the previous speaker, Mr. Knudsen, is a part of. As a scientist, you have to apply for the data you wish to access for your research. It has to be the access has to be by a specific purpose. So you only get a limited amount of data within the given purpose. So for the future healthcare system, I actually think that this is it's a very good way of having a balanced access to health data, making sure that the patient's privacy is not violated. But at the same time, you should also be aware that the system needs to have a very good flow, so the scientists are not forced to wait 6 months to getting these data to be able to do the research in a faster manner. So it's a balance again against the privacy, but also giving swift access to the researchers so they can perform their important research on the data. Thank you.
Thank you very much.
Does anyone have any other questions? So the question is coming from Mr. Musong Kim of Hira. So my question would like to go to Mr. Thomas Saxfield. So are you present? Are you online? Nice to see that you're there.
Suppose you have a patient who has been transferred to you. Looking at the medical records, there are a little bit or many differences in diagnosis and prescription of the disease. If you find that the previous prescription was wrong, what can you do in that Medcom system? Yeah,
Yes.
that's it.
So the question is, if I have a patient and with some medication that was prescribed wrongly, so okay, I can do that in my system in FMK, as the common the medicine system. I can go in and delete the medication so that the patient cannot take it out from the pharmacy. So and of course I can inform my patient also, and I can make a correspondence to the patient or SMS, or I can even take the phone and call the patient. So That's very easy for us to do. Does that answer your question?
Thank you.
Thank you.
Oh, there is one more question from the floor. So nice to meet you. My name is Kim Yeon-gyun. I'm a reporter from GDNet. So my question goes out to Mr. Chang Young-jin. So you said that the Digital Healthcare Promotion Act would be legislated in August. I would like to know the gist of this legislation once again. Would you be able to offer that information?
This is not fully confirmed, but there are 4 main agendas in the law. First thing is the concept of digital healthcare. This is more than health management. This includes medical treatment, so the concept will become wider. And secondly, as I said in the presentation, the PHR sharing methods, the limitation, strict limitation from the previous law, we want to enable the third party to accept the data, but we will have a management system for the data when it's given to the third party. Thirdly, the second was PHR use of individuals, but third is for the research purpose. For example, the big data, de-identified data is current use, and we only have guideline at the moment. So there are many issues in practice, but we want to resolve the issues that collide with current laws. So we want to facilitate and promote the use of PHR. You can see the 3 main agendas in the law.
Hope that answers your question. In the interest of time, we will have to wrap up the Q&A session. Thank you very much for your passionate questions and insightful answers. So for the last 2 hours, we have had intention presentations. Now it is time to officially close the 2022 Health Big Data Future Forum. I hope this event was an opportunity to learn from Denmark's advanced PHR system and guide us to a soft landing of our own PHR system as well. Thank you all for your participation, and in particular, my gratitude goes out to our friends from Denmark, and I would like to officially conclude today's forum. Thank you very much.